So we're going to start with the last session today. It is a pleasure to be here in this big room, and it's a pleasure to present and to be moderating this session. I'm going to present myself. My name is Pedro Gullón. I'm an epidemiologist and I work as an assistant professor in Universidad de Alcalá in Spain, a small town close to Madrid. Really happy to moderate this session. As I said before, I think we are going to enjoy different kinds of presentations with experiences from different countries. They have some things in common that we might want to discuss in the end if we have time. But well, we'll see how we go with the time. Each presentation will be 10 minutes. If you want, when you have 1 minute left, I can raise my hand. Just raise my hand or say something if you want. Yeah, I will say 1 minute. That's quick enough. And then if you want to go to some final remarks. Okay, I think we have enough time, so not a lot of pressure, but let's try to keep in time. Then we'll have questions about each presentation. I will go to the next one, and if we have time in the end, we will have a discussion with all the people that is in the floor. So let's start. We'll go with the first presentation. We'll have, if I'm not mistaken, sorry for the people there, Vitor Pessoa, which will be presenting shared sanitation and safety issues in impoverished urban settlements, design implementation for slum upgrading projects. The floor is yours.
So thank you, Pedro. Hello, everyone. It's a pleasure to be here today. So my name is Vitor Pessoa Colombo. I am an architect and a PhD student at the Federal Institute of Technology in Lausanne, Switzerland. And the research that I'm presenting today is a part of my PhD thesis that has been elaborated with the help of partners from Kenya, Ivory Coast, and Switzerland. And as the title suggests, today we'll be focusing on sanitation issues in the context of informal settlements in Nairobi and Abidjan. As I'll try to argue today, guidelines and interventions that aim to improve access to sanitation need to be more sensible to the spatial context by addressing urban morphology and location as key determinants of efficiency and adherence to sanitation. So just a quick outline of the presentation. I'll start with a short background and rationale for the study. Then we'll have an overview of the methods, which are mainly based on georeference data and the geospatial analysis. Then I'll show you the preliminary results of the study and with some discussion and conclusions. So where did this study come from? We observed that today, of course, I'm preaching to the choir here, but there are huge challenges concerning access to safe sanitation and water services. What you can see on the graph on the top left is in blue what should be invested to achieve safely managed water and sanitation by 2030, and in gray, in the light gray, what is actually being invested today. So there is a clear financial challenge to achieve these goals. At the same time, we see on the top right, we see a rising slum population across the world, especially in African cities where our study sites are located. And also we see a trend to expand the share of what we call non-network sanitation technologies, which are often shared and hence not suitable if we follow strictly the guidelines given by the joint monitoring program by UNICEF and WHO. What we'll do here a little bit is raise some questions regarding these standards and to see whether sharing is really the key component, or there could be other components that should take into consideration. Also, the key message that I'll try to bring here, that it's not only about having or not having improved WASH, we need to, by wash, we mean always water and water, sanitation, and hygiene. What we need to do is to contextualize these infrastructures and to see where they are placed and to see to what level people are actually using these facilities, to what level have adherence to these facilities. Recent studies have already pointed to that problem, raising some difficulties to assess impacts of water and sanitation interventions. Also, there is a greater concern with gender issues, notably around safety for women to reach sanitation facilities. So on this basis, what the study proposes to do is to examine the use and impact of sanitation facilities in very different urban typologies. By urban typologies, I mean morphologically different environments in terms of building compactness, covered area ratio, entropy of built environment, density, and other factors. So we conducted over 1,700 household surveys in 4 sites located in Abidjan, Côte d'Ivoire, and Nairobi, Kenya. And here are some of the results. Oh, well, just to illustrate a bit how the process went, we used open source technologies to conduct the household surveys, Kobo Collect to do the questionnaires and georeference all the data collected. We also mapped the sanitation facilities to see exactly where they're located. And we worked a lot with GIS models. So one finding that struck us very quickly was the relevance of location and its impact on the perceived safety. And this was very strong, for instance, in Nairobi. Depending on whether the toilet is located inside or outside of premises. And by premises, I mean, it could be a courtyard, for instance, a courtyard with 10, 15 households sharing a toilet. But the fact that a toilet is located in a totally public location, like a street, affects heavily the perception of safety. And at the same time, we also found through odds ratios tests that perception of safety impacted the risk of diarrhea. So indirectly, toilet location is impacting the risk of diarrhea, because what happens when you do not feel safe to use a toilet, you don't use it. So you find an alternative, which is maybe a bucket, a plastic bag. In Nairobi, they have these things called flying toilets there. So you end up with environmental exposure that enhances enhances the risk of diarrhea. Right. So this is just some details about the results that we found regarding the location of sanitation facilities. Here we see that the fact that in both sites, in all 4 sites, in Nairobi and Abidjan, in 2 different countries, we found a common trend that toilets located outside of premises, outside of a courtyard, independently whether they are shared or not, the most important factor was about their location. If they're in a public location, they impact on safety perception with an odds ratio going up to 24 for combining all the data for both sites. Now we also noted, running spatial analysis, we also noted that there is a significant spatial autocorrelation of households complaining about lack of safety. This is just an example of one of the sites in Abidjan, where you can't see. On the top left, you can see a map showing colored dots that count the number of neighbors complaining about lack of safety, and the dark red dots show areas where you have a lot of people complaining about the same issue. So we found 2 clusters in this community. And this motivated us to investigate whether urban morphology, besides the location, the type of location, public, semi-private, or private, besides that, we wanted to know whether urban morphology itself impact also on the perception of safety. And to do so, we ran several tests with different morphological indicators, a number of neighboring structures, which you can see on the bottom left, the entropy of the built environment, so how homogeneous and how well aligned the buildings are, which you can see on the bottom right, and some preliminary results show that for a couple of sites, we could find common trends, for instance, regarding distance to toilet. There is a critical threshold around 30 meters where you're almost sure that people won't feel safe to use the toilet anymore. There's also a density indicator, number of neighboring structures. That's the more neighboring structures you have, the higher the risk of feeling unsafe to access the toilet. And also for 2 sites, we found that altitude, topography was relevant. And this is certainly explained because these are sites located on valleys. And as you went down the valley, people would tend to feel more unsafe. So what does it mean in terms of design and policy making? So going back to the current standards of what's basic and limited, improved and improved sanitation. So maybe we should not only ask whether it's shared or not shared, we should start asking where is the toilet located? The WHO and UNICEF already they already suggested the inclusion of this question in national censuses. But for instance, in Kenya, this question is not included, so we cannot know where the toilet is located. And more globally, in terms of project design, we should, not only consider quantitative aspects. It's not only about how many people for how many toilets. And what's the technology of the toilet. We should also think about, from a more qualitative perspective, how we are distributing these toilets. And we need to look at the gradients from public to semi-private to private spaces and see how we can optimize the distribution of toilets based on that. Of course, there are several limitations to this study. For instance, we could not explore the specific reasons for the lack of safety. We would need a more qualitative analysis for that. There are also potential confounders that have to be addressed yet, like education, which is associated with the perceived safety. And of course, different people have different thresholds of safety. So just to conclude, key message for designers is really to look at how we can make spaces more livable, as we saw just earlier today. And it's important to know that spaces that foster a better social coherence and that foster, that create a sense of confidence in your neighbor can also impact in many dimensions, including access to sanitation. And with that, thank you very much for your attention.
Thank you very much for an interesting presentation. Are there any questions? Yeah, sure, over there. Ese micrófono, sí.
Thank you, Vitor. It's not too much of a question, but more just to say I really agree with it, because we've chatted, I've done something very similar. And I think the important story is that physical presence of services and that physical access doesn't equal utilization. And so I was just wanting to know from you, does the community understand that just because there's toilets present, it actually doesn't mean they have full access to them? Has that sort of resonated with them? Because that's also from an equity point of view, if they don't realize that they actually don't use them, and even those, the government might say, these are your toilets, do they understand that there is this equity issue?
Yeah. Thanks for your comment. This is spot on. Presence of infrastructure doesn't mean use of infrastructure. That's the key message. Now you pointed towards one of the limits of the data that we have. So we asked this question, do you feel safe to use the toilet at any time, only during the day, or never? This is the only information we have. We would need a series of other layers of information to understand, how really the community perceives safety, and what are the reasons, the underlying reasons behind that feeling of lack of safety. So this is clearly one of the limitations of this study, which is too quantitative, maybe. And I think that's what usually happens with research. Your findings usually raise other questions that require more investigation. And but I thank for your comment. I think it's very relevant.
Are there any further questions? Yeah, up there. No, let's. I think we need the mic.
Please use the mic. I can't.
So you refer? No. Before we have another one over here. Yeah.
Okay, then let me just go then. Yeah. Okay. Nice presentation, Victor. My question is, it has more to do with can you hear me? Can you hear me? Yeah. So Victor, my question has to do with how you created your urban morphology. So basically, did you kind of create some rule sets? How did you determine the things you consider to define your urban morphology? And the model you created, are they transferable? Can it be replicated in another maybe city and try to use it to actually develop the morphology of that particular city or any African city?
Thank you for your question. Really interesting. The metrics that are used to quantify morphological indicators, they are based on previous studies that look at informal settlements around the world. And they extract metrics related to entropy of the built environment and density. So I did not invent these metrics. There is this group at the German Aerospatial Center, the DLR. They have a couple of publications on the morphology of informal settlements across the globe, notably by Taubenbock. So this is my reference for the metrics themselves. But as you rightly pointed out, the morphology changes with culture. The built environment is a reflex of society. And because you have different cultures, you have a different built environment. And this is also true for informal settlements. For instance, in Abidjan, you have the typology of the cour, the courtyard. Usually houses are arranged around a courtyard, which you find much less often in Nairobi, for instance, where you have a typology that is more alignment of shacks, metallic shacks. So this is a work in process, and that's definitely one of the missing aspects of this research. We found common trends. Now we need to explore the differences between these sites in Abidjan and Nairobi. Yeah.
Okay, so we have a final question over there.
Hi. Oh, that's so much better. Thank you so much for your presentation. It was really great, really well delivered. My name is Laura. I work at Imperial College, and I'm doing kind of similar research to yours, but in drinking water patterns. And so my question to you was, in the map that you presented to us, you highlighted 2 zones where people felt particularly insecure, and those were the zones where people didn't use the toilets. And my question relevant to that is, were those 2 zones 2 kind of distinct neighborhoods within the slum, or were they all part of the same slum? And so the distinction was really topography more than anything else?
Mm-hmm. So these 2 areas, they were actually quite similar. They show similar indicators of density, entropy, and they're also, I mentioned the importance of topography. They are also located at a lower part of the community, so at the bottom of the valley. So the hypothesis is that these spatial configurations are affecting the perception of safety. At least we find an association. We could, when you look at informal settlements, well, with my experience in Brazil, Kenya, and Ivory Coast, you usually see periphery of the periphery. You have the better off part of the informal settlements, and at some point you have the worse off part of the settlements. And what it looks like is that the vulnerability is highly concentrated in some spots that corresponds to these areas where people lack of safety. I don't know if I answered your question.
Yeah, you did. That was perfect. Thank you.
Okay.
Oh, thank you. Thank you very much. We'll move to the next one. So a big applause again.
Sure.
So this is a global conference. So we moved from Nairobi to Indonesia. Now we are going to go to the next presentation entitled Understanding Interactions Between Waste, Wastewater and Health in Makassar, Indonesia.
Thank you. And I'm honored to be amongst such a great panel today and to see some familiar faces as well. I want to acknowledge my other researchers on this project, on this activity, coming from LSKP, which is a local institution, and our partners, the International Organization for Migration. So you might be asking why an urban health project is looking at garbage. Well, let me explain first a little bit about the project. If you haven't visited our booth just outside this door, Building Healthy Cities just ended last month. We are a 5-year project funded by USAID, and we took a systems thinking approach to urban health, which led us actually toward healthy urban planning, because we worked across all of the areas that had social determinants of health. This means that that outer circle you see on the right side encompasses all of the different activities that we were led to from our systems mapping and systems thinking. We worked within the government and with citizens and stakeholders to improve multi-sector engagement, citizen empowerment, and data-driven learning. And across all of the interventions and research that we did on these 5 years, we pulled this together into one compiled set of recommendations and recommended actions called the Healthy City Action Plan. This was built with the city government all the way through, so they had full buy-in, and what we did not fund and they did not fund within this plan, we reached out to other donors and private sector to look to fund those activities. So we worked in 4 Asian cities, but I'm going to focus on Makassar, Indonesia today. And that social determinants of health systems thinking approach led us into all corners of the city. This infographic gives you a sense of the breadth of the work that we did under this project. But today, I'm going to just take us to the bottom right corner of this image, the community-based wastewater management work in what are called alleys, which is one of the lowest administrative units in the city. So why are we doing this? How is this connected to health? So the systems mapping that we did was really to give us a perspective on the entire city context and how things link together. We also did journey maps, so many maps, that gave us a perspective of the individual. So we had identified 3 or 4 really key issues in each city that needed to be tracked over time. And so these journey maps allowed us to track in one neighborhood, one issue every quarter for 4 years. One thing we noticed when we first came to Makassar is that many of the low-lying, lower income areas were very prone to flooding, and it caused the wastewater to bubble up into the houses. Now, obviously, this has health implications, but we wanted to understand better why this was happening. And these journey maps led us to understand that actually there was a big interaction with solid waste and improper solid waste management in clogging the drains that backed up into the homes that caused the health issues. So we funded a study working with LSKP, which is a great group in Makassar. They're affiliated with the Hasanuddin University, to understand a few different things about this. First, to really flesh out the context around waste, water, and health, to understand some of the gaps in service delivery and behaviors that might be leading to this issue happening again and again, and then to really work together to come up with some solutions. This is a participatory research study, and I want to get on my high horse for a second because this is the third day of a conference where we're hearing a lot about academic research, very important. But throughout this project and throughout my career as a researcher, I've always wondered, with the standards that we have for passing institutional review, all you need to be able to show is that you are getting informed consent that's not coerced and you're not going to be causing any harm. But I think we should actually be going a step further and saying clearly what the benefits are, especially in this current age of Facebook and Google, where we're really talking about the value of an individual's data. Survey data is valuable. People are giving us their time and their information, and we should be clearly figuring out what's going to be coming back to them in terms of benefits. So we did 3 of these participatory studies. This is the only one in Indonesia. The other 2 were in Indore, our Indian city. And we're learning by doing. Participatory action research is not new, but we've been trying to extend the participation beyond just having them help us collect the data, but actually have these communities help us define the research questions, and then going to them first with the results so that they can help us interpret what we're seeing and come up with recommendations and solutions. I'll get off my high horse now. Okay, so this is a mixed method study. We had 4 different data streams: social mapping, which is a traditional participatory action research methodology, which brings the community together to understand what are the physical and natural assets in that area. And in particular for us, understanding what assets were related to waste and water. We had focus group discussions, a household survey that was represented to the RW level, which is the second lowest administrative unit. And then a subset of those households allowed us to have them do a waste audit, which meant they were counting and weighing and segregating their waste. So we had a good understanding of what types of waste and how much were coming from the households. These were all collected in January of 2022, and we came back in June to do data walks in each of the RWs to show them the data that we'd collected and collated and analyzed, and have them help us understand what we were seeing, interpret it, and then discuss solutions. I encourage you to come to our website to see the full report, because I'm really just going to be skimming the surface of what we found. But to give you a taste, this flow diagram is one of the things that came out of the social mapping, so that we could understand not just what waste was coming from the household, which is what the audit gave us, but where it was going and how did it end up in the places it shouldn't be. And so just to highlight a few things, things largely fell into either managed waste, meaning it went to the landfill, or in Indonesia, there are things called waste banks, community waste banks. These are a really great idea where people can trade either rice or oil, they're recyclables for rice or oil or other commodities, or in some cases, cash. And that gets taken to the central waste bank to be recycled. These are the 2 sort of managed waste options. Unmanaged waste means that it either gets burned or it ends up in the canals or vacant land. And this is where it has that interaction with the wastewater, which is causing some of the flooding that we're going to be talking about. From our research, about 12% of households had some form of had no form of garbage collection available to them. Now, not everyone who had it available used it. And when we do the waste audit, we saw by weight that about 23% of the waste coming from the household was unmanaged. So it fell into that bottom category. I'll stop there on that point. There's a lot more to go into on that, but again, I'll direct you to our report. It's really fascinating. I never thought I'd be this excited about garbage. When we start to look at water, Most households had some access to pipe water, and that tended to be the primary source of daily water, but 25% also reported relying on bottled water. Now, where the waste banks are not operating, that means they're not getting recycled. So that's another stream of garbage coming from structural issues around water. Most households had a toilet, and they all had some sort of sewage management system, but that included plastic bag disposal of their garbage. And open drains are the most common type of sewage management. Closed drains are considered better, but the way that they were being built, you could not take the covers off. So if they did get clogged, they could not clean them. And flooding was very common in both types of drains throughout the rainy season, which, if you know Indonesia, can be quite rainy. So when we start to look at the confluence of these issues within the system, 49%, about half of the respondents, said that there was visible blockages or buildup of solid waste in the drains nearest to their homes on a regular basis. So this is what's starting to cause that regular flooding of the homes. Again, there's a lot more in the report, but to highlight how this sort of comes together to affect health, we looked at 4 areas of health that could feasibly be affected by flooding of wastewater into the home and garbage. The most common that was reported was digestive tract diseases, but actually the one that showed up most often during floods were skin diseases. So about a quarter of the respondents had experienced skin diseases in the last 3 months, and they were about half of those were most likely to occur during a flood. Okay. And so what was interesting, again, combining some of these different streams of data and coming back to the data walks, we heard we have these numbers, but then they were saying, yes, but skin diseases are not that big of a deal. There's a very big normalization of liquid waste, meaning sewage, and having contact with it because of this regular flooding in the homes. So in the data walks, we really tried to ideate solutions, and they came up with 6 of these. Some of these are fairly intuitive. I'll just focus on the ones that maybe aren't so intuitive. This reviving of the community waste banks is a really big deal. These were a great idea. They were started in the 2010s, but they really lost momentum, and particularly during COVID, a lot of them shut down. And part of the issue was lack of viability because they couldn't get enough value out of the recyclables being brought to make enough money to pay back in the bank. So you see this quote on the right. This came from one of the directors of one of the defunct ones saying, if we could just get things like plastic shredders, this will help us to store it and to sell it for a higher value to be able to then pay back our constituents who are bringing the money, which would then again help to increase that behavior amongst the community. We talked about the sewer drain. That's something that came up, changing that design. Something that was really interesting that we did not probe on, but came out naturally from the discussion is that the integrated health service post at that alley level, they wanted to not only have them supported to treat some of the diseases, but thinking about, and I didn't talk about this on the first slide, nearly 60% of the garbage coming from the home was organic food waste, which can be composted and can be used to grow food or be sold for profit. And there's a big nutrition issue, and the Posyendos have been struggling with how to address the nutrition issue. So the suggestion from the community was, let's use some of the space near the Posyendos to have an urban farm where we can grow nutritious foods for our children from the compost. So again, thinking about all those different streams coming together in the system to come up with a solution. If we think about the implications and next steps of this, we did already present this to the mayor of Makassar so that he can think about how this might affect some of their work plans and funding in this area. Bapeda, which is the local planning office, really has taken up this issue. There's a group locally called Kotaku, which Cities Without Slums, that has been looking to put money into some of these issues. And so having this type of ground level information coming up from the communities themselves, not from us, has been very helpful for them thinking about planning. And already we've actually seen through the results of the study, a local CSO has helped one of the waste banks receive a plastic shredder to try to work on this. I'm going to end on the quote that you see here, which is, I think, really important, again, to bring us back to where we need to evolve academic research. And I would encourage any graduate students in the room to really think about this as you're thinking about crafting your career. What value are you giving back for the data that you're getting? And this is something we heard across all 3 of the participatory studies we did. Multiple surveys have been done in this area. This is the first time anyone had showed them their data from those studies. I think that's important. That's the first step. It's not the only benefit that should be there, but it's the first step toward giving some of the benefit back. I'll end with that. Thank you very much. And please do stop by and see us if you haven't already, and we can give you more information about this and our other work.
Yeah, see. Are there any questions for Amanda? Okay. Yeah.
Thanks. I'll be that annoying kid in the class who always has a question. Thank you, Amanda, for your presentation. I had more of a technical question for you. You did a lot of, your team did a lot of surveys, it seems. I think it was close to 2,000. And I was just wondering if members of your team personally went out and did those surveys, or if you used enumerators. And let's start with that.
Yeah, so we trained 27 enumerators from the community to help collect the data. This is usually the point where participatory research pulls in the communities for collection of the data. Having done several of these now, I actually don't know that that's the best place to use the community's time and effort. In our new project, we're going to be thinking about how to refine this approach. I think actually having them as advisors is great, but having people who are trained in survey data collection to either pair with them or to do the actual data collection is maybe the best way to do that. We didn't have major data qualities issues on this survey, but there is always another layer of ethics in having a neighbor or someone collecting data from you, particularly if it's sensitive health data. So yes, we did use the community for collection of the data, but I'm not sure we'll go that route for the next one.
Okay, so my next question is, how did you get those enumerators to agree to help you? Did you offer them some kind of compensation, or were they just inherently committed to the cause and that's what motivated them?
We did not provide enumeration. They were part of the, we had initial consultations to refine the research questions. So a lot of these folks had come for those consultations and got interested in the topic or had a personal issue around wastewater flooding that made them want to participate. But we did not, in none of the studies did we actually provide financial remuneration.
Did you provide any kind of other compensation, or not really compensation, but perhaps, some kind of knowledge exchange or goods exchange that might have helped them to commit to this project? Because I think 2,000 households must have taken a while to.
So it's 460, but it's still a lot. And really, we want these guys to be empowered to. So I guess the benefit, and this is what I mentioned before, is what benefits are they getting from this? We continue to train them on advocacy skills and how to use these data going forward. And we did clearly state that this information will be put in front of city officials like Bapeda and the mayor. So they had a investment in that way, and that their voice and their work would be hopefully put to good use to get them some improvements in their community.
Thank you.
Okay, can we move the microphone over there? Yeah. Please don't break a leg.
Full disclosure, I'm from USAID and I was the funding agency for this project. I just wanted to add, in Indonesia, there is social context that really supports these kind of efforts. There's an RT, which is a very low-level administrative unit that often does community cleanup, does a number of things. And the flooding that Amanda referred to was a serious community threat. So that was partly an incentive to find some way to respond. But in the context, it was not surprising that there was that much community spirit.
Yeah, and I'll just add, so both Indore and Makassar had a strong culture, and we saw this in the systems mapping. There was a strong culture of, if you speak up, people will listen. There's a very good, strong civic mindedness in both of those cities. In Da Nang, Vietnam, they had social cohesion, but speaking out was not part of the culture. And so we didn't end up doing participatory work there. And this is something we need to think about, but it is working within the system, trying to pull the levers that we have to be able to give the community more power in the decision-making and funding process.
Okay, so thank you very much. Let's move to the next one. Thank you. So let me see the notes. Let's go to the next presentation, which will be entitled Unlisted and Vulnerable Population and Universal Health Coverage in India. All right, yeah.
Good afternoon, everyone. First of all, I would like to say thank you for making me the part of this panel. And I am representing Mukesh Sharma, who is the ED of Pesua, India. I'm a gynecologist. Actually, the topic today which we are going to discuss is finding hidden and unlisted slums, help ensuring universal health coverage. So we will be talking how we achieve by mapping and listing of the unlisted population under the TCI-HC program. So in my presentation, it will go like the brief introduction of the program, why urban health, hidden and unlisted slum population, finding most vulnerable slum population, and the key results. Why focus on urban health is very critical to understand, and we had been talking during the plenary sessions also that we have to work together, and we should identify each and every individual of the population to achieve universal health coverage. So this is a very interesting slide which shows the phenomena of 2, 3, 4, 5. What is there? Like word urban, if we see that urban population, urban word implies of very great things, great education, great lifestyle, great living style, great money in the hand, so many things. But actually what is happening? The happening is we are not able to see city within cities. If we see within cities, only with a distance of 1 or 2 kilometers, there is a lot of difference. So we need to understand more that where are these hidden population. So today I am going to talk more about the hidden population and how we are going to cover those population. So rapid urbanization is happening in India. And this is by 2030, we think that the population will be achieved to 590 million with the rapid growth of slum population. And this 2, 3, 4, 5 phenomena is also going to happen like in country. If population increases by 2%, then urban population increases by 3%. And the large city population increases by 4%. And further, the slum population increases by 5%. So we need to focus more on that increase of 5% for their health needs, and what are the interventions we should plan for the better health of those population. So for understanding more about urban India, the India contributes to 18% of the world population. Indian population contributes 18%, and out of those 18%, 32% are in urban area. And 32% of urban population is 377 million. And then out of this, 289 million are covered by NUHM, that is National Urban Health Mission, which is contemporarily to government and works in the mission mode to improve the health of the urban poor. While 94 million is estimated unlisted, which is huge number. Unlisted population are also huge in number. Sorry. So potential coverage of urban health program, the TCI-HC, the Challenge Initiative for Healthy City program of PSI India, is working in 3 states of India. and the cities which have been identified has the rationale behind them. Like in 161 cities, the population coverage is only 15%, and 15% is cities cover 60% urban population, that is 172 million. And 85% cities cover 40% of the urban population. So this implies that if we work for 15% of the population, that is 161 cities, we can achieve 60% of the health coverage. So it is very important to prioritize and select the areas to have the greater impact. So the exercise was in the program that listing and mapping, which has resulted in accounting all slums and the population. So hidden areas identified are great. I think the people who have worked in India might be knowing different type of slum population, like there are listed slums, unlisted slums, authorized slums, unauthorized, legal or illegal slums. So there are many types of slum population, like there are rack pickers, rickshaw pullers, in construction sites, there are laborers who are just for few days or few months or few years at a place, and then with the urbanization, they move further. So we need to identify those hidden population if we want to achieve the health for all. So in universal health coverage, we achieve only when we identify each and every individual of the unbared population, and few work has already been done. In the following slides, we can see few results of the program. If we see, there is annual increase in annual client volume for urban health coverage after listing and mapping of the slums. At city level, there is increase only 79%. And if we see at UPHC level, that is urban primary health centers level, the increase is 175%, which is highly significant. The client volume has increased a lot with the start of the program. So key recommendations are: the hidden population in urban areas are most vulnerable and should be included in all the health provisions, not only family planning or any health intervention. In all the areas of the development aspect, those should be included. Universal health coverage can be a reality if none of the population is left behind, that I have already emphasized. Rapid urbanization will facilitate the existence of unauthorized, unlisted, and hidden slum population, and listing resolves this solution. I want to highlight few points of the program that in the beginning of the program, there are many organizations which are working, like ICDS is working, Urban Health Vision is working, and National Urban Livelihood Mission is working. Urban local bodies are working. There is national polio surveillance program. So all the programs are doing this kind of exercise, but there was not a final concrete list. So for identifying the unlisted population, we did the exercise of collecting the data and then collating and review the data with different stakeholders to make the final list of the unlisted population. And that exercise is really very helpful, and it should be done on the regular basis. So finding most vulnerable slum population is key to have improved health indicators as well. Universal health coverage requires identification and listing of each and every individual to get the improved health needs. So thank you so much. I want to say this is for the SARA. If we, like in TCISC program, we have identified the need for family planning, because that program works mainly for increasing the access of family planning. So if the SARA's need or the woman's need is met, then we are sure that we can reduce the TFR, that is total fertility rate, or maternal mortality ratio, which is a very important indicator for health. So thank you so much. Any question?
Wow, really big effort in doing that. Are there any questions? Yeah, sure, over there.
Did you face any community resistance? Because when I have worked in some unlisted slums, for certain parts of the population, it benefits them not to be on formal roles. So did you face resistance?
I was there in the previous panel also, and there was one program in which the challenge was presented like that. Some program implementers and donors are also like having some objections or maybe some resistance for including the unlisted population. But in India, we don't find this kind of challenge. Rather, unlisted populations or the slum population which are covered, they are more grateful. They understand that they are also involved and they are part of the community. And the other community members also, they don't have any objection. Rather, they, like being a gynecologist, I would like to share my experience. Once I was working in a big district women hospital in Lucknow, Uttar Pradesh, which is a big province in India. So we often see that women are coming unregistered. We often say the woman is unbooked. Suppose the woman is coming from delivery, but she is not even having any previous card or any previous information. Once we asked, why don't you come for checkup regularly, what is recommended by WHO? Then they say, we don't know, nobody has come to me. So in India, there is a entity with the name of ASHA, Urban Social Health Activist. Those are the women who work for the 2000 population. They go house to household, from house to house, and discuss with them, talk with them, and address their health needs. So ASHAs are also very important pillar under this program as well. Because in TCIHC program, we are not working ourselves. We are working as a catalyst with the government. So we on the driver's seat, there is government only. The government is doing the program. TCIHC is just helping them as a catalyst. So listing the unlisted population is helping them to make the actual real list of the slum population. So ASHAs have not reached to the unlisted. That is why the women are coming unbooked. Anemia, with a severe anemic woman, because nobody has reached them. So there are high-risk women who is lying in the community, high-risk children who are very anemic, very malnourished. Nobody has reached them. So once we reach them, then only we can achieve the universal health.
Are there any further questions? Well, if yeah. Where's the mic? The microphone is what?
Thank you. So is there any political issues any kind of illegal immigration? Maybe is one of the reasons they are not wanting to disclose their identity. Because I'm an architect planner, so government is doing on the base slum redevelopment programs, institute redevelopment. So we have visited in different slums. So sometimes they are hesitating. We are finding maybe one of the reasons is illegal immigration. So they are not trying to identify themselves. And Aadhaar card and voter card. So if they have that hesitant because they should be removed from this place and to be relocated to the other places. So is there any chance?
Actually, for migrant population, sometimes who are for very short period at a place and then move further. Sometimes there is, like you said, that there is Aadhaar card. Basically, Aadhaar card is a national identity. So it has nothing to do with the state to state or something. If they are migrating also, then there is urbanization is happening. They are in rural is included in the urban. So actually, it's not having any challenge of not having Aadhaar card or something.
Okay, thank you. So we'll move to the next presentation. Thank you very much again. A big applause. Instead of going to the last in-person presentation, we're going to have a couple of videos because Ivy Chumo was not able to come to the conference, but she sent the presentations by video. So we're going to see the videos of the presentations.
Going to be presenting about informal social accountability, mechanisms in WASH in childcare centers in Nairobi's informal settlements. And this is part of the ARISE consortium work, and I work at the African Population and Health Research Center. Children in childcare centers lack quality WASH, yet WASH is central to child health, and you can already see how the WASH, the sanitation facilities are so poor, and the same children would use and wash, including those with disability, and wash their hands using water from the drainage and drink the same water. And this leads us to try to figure out about the social accountability triangle that has parents, childcare providers, and policymakers, whereby in most cases the full triangle is usually a formal accountability system, while parents and childcare providers in most cases operate informally. And since the provision relies on informal social accountability mechanisms, and the mechanisms are usually unrecognized and undervalued, for this work, we really want to explore the informal social accountability mechanisms that are being used in childcare centers, so that it could be a lesson, it could be a best practice for other childcare providers who would who are usually mushrooming. And just as the study was done in 2 informal settlements in Nairobi, and before the data collection, we had a community outreach and also the school outreach. And it was qualitative in nature, using ethnography, particularly governance diaries. And governance diaries is a basket of methods that included observation of WASH facilities, reflection of the occurrences, participant diaries, informal discussions, and in-depth, and all these 4 approaches informed the in-depth interviews that were done bi-weekly for a period of 4 months. And this was the distribution of our study participants, and we used a framework analysis. There were 4 major themes, but I'm only going to focus on informal social accountability mechanisms. And from our findings, we found that there were discretionary actions that included rewards, sanctions, and peer mentorship. There were also some informal accountability mechanisms that included respecting the demands for WASH services, valuing or prioritizing WASH needs, even at the expense of needs of the parent, and trust between the actors, to the extent that they would even allow for credit to the parents, that I would bring my child without bringing water, but then negotiate to bring water later or when you get the money. There were also facilitative behaviors that included a sustained communication on a weekly basis, or when you're picking your child from the school, reporting on complaints on poor WASH services, on lack or delayed payment of WASH services, and reliability in service provision and credibility. We discussed our findings by the fact that parents using principal stewards theory where the principal were the parents and the stewards were the center managers. And according to stewardship theory, a principal stewardship theory, the principal and the stewards would work together to achieve a common goal. And for our case, the common goal was wash provision. And in the attempt for the principal and steward to operate, they came up with some initiatives or mechanisms that would help them to ensure that their goal could be achieved. And they discretionary actions, norms, and values, and facilitative behaviors that enable them to avail WASH at the childcare centers. And because we could not proceed with all the 10 mechanisms that were identified, we did pocket voting. Pocket voting is whereby the community members or the participants of interest, for our case, parents and childcare providers, would vote for the best mechanism based on how it has been operating in their context. And it is from that we were able to identify rewards for WASH service provision to be a mechanism that was widely applicable, and respect demands for WASH needs of children as also a key mechanism, and also sustained communication. So we wanted to go forward and understand deeper about these mechanisms that were widely applicable and described as practical. And we did reflexive workshops, which is an more of interpretive and collaboration, and it acts as a dialogue and validity testing, because we get to describe each, how it operates, and so forth of the three mechanisms. And we went ahead to do a co-learning whereby the actors who had applied the three mechanisms longer than the rest would take through the others on how it operates, the advantages, the shortcomings, and so forth. In conclusion, it is valuable to explore social accountability mechanisms, and it's important to note that informal social accountability mechanisms exist regardless of the presence or strength of a formal social accountability mechanisms in a sector. Even like in a water point, or even when you're going to buy something, sometimes there are informal social accountability mechanisms that would help you get to understand the operations, rather than waiting for the formal process that would take longer. And it's important to note that informal social accountability mechanisms are not limited to managerial and administrative ranks in the sector. This is because even the parents or even the childcare provider who are not at the management in any way are able to operate using the mechanisms. And we recommend stakeholders to explore and build on existing social accountability mechanisms. And the fact that sometimes it's important to go beyond tangible resources. And I acknowledge the GCRF, UKRI, who are funding this project, the African Population and Research Center where I work, the ARISE consortium that this work is part of, study team, the community, the participants, the research assistants, my supervisors, Professor Penny Howard, Professor Helen Elsie, and Professor Blessing Mbero. And thank you so much. If you have any question, please share using my email address, ivychumo@gmail.com. And I am actually very sorry that I did not manage to attend this meeting. Otherwise, thank you, and have a good evening. Thanks.
If you want to ask questions to Evi, you have to send her an email because she is not here. I think we have another video.
At the African Population and Health Research Center, I am going to present my work on social accountability actors and networks and their role in WASH in childcare centers in Nairobi, informal settlements and youth governance diaries. This is part of Arise Consortium's work. And good to know that there are more women who are working outside home for long hours, and therefore they're mushrooming childcare centers to fill in the vacuum. And when children are in childcare centers, it's always hope or a wish that SDG goal number 6 of access to water and sanitation is achieved. And it's also a wish that SDG goal number 4 of ensuring safe environment in the school setup is achieved. And also that through partnership, the SDG goal number 6 and number 4 could be achieved. And despite that, there are many institutions gaining access to improved WASH. Childcare centers in informal settlements have poor access to WASH. And as you can see in my right, how the WASH services are dilapidated and they're just in poor condition. And we want to understand how existing actors and networks operate in the childcare centers, because you find that WASH is under the Ministry of Water, it's under the Ministry of Health, it's under the Ministry of Education, it's under the Ministry of Social Protection. And so we based our work or embedded in World Bank accountability model and also stakeholder theory. In the World Bank accountability model, there is usually a long route and a short route of accountability. The long route is where you go through the government for the government to provide punitive measures to the service provider. So it's usually long and it does not solve the immediate problems in the childcare centers. And therefore, in most cases, the shorter route of accountability where the parents and childcare providers or managers work direct offers most immediate solutions to childcare needs for WASH. And it's usually motivated by the stakeholders theory, which has tenets on authority, interest, and responsibility. The more there are responsibility, interest, and authority, the more the networks become more stronger. And the study was done in 2 informal settlements in Nairobi, and we subdivided into villages or polygons for distribution or for ease during our sampling. And before the data collection, we had community outreaches and also school outreaches, because we were collecting data from both the parents and also at the school setup. And our study design was qualitative in nature and was ethnography, particularly governance diaries. And governance diaries is a basket of methods. And for our case, we had observation of WASH facilities at the childcare centers. We then have reflections to reflect and deep dive into the output that we have. There were also participant diaries that they would write on a daily basis in respect to the actors, networks, interest, authority on a daily basis. And there are also informal discussions. All this informed in-depth interviews that would happen bi-weekly for a period of 4 months. And we had 4, these are the distribution of our study participants. We used a framework analysis, and these were the themes that included actors and networks, roles, authority, and interest. And other than that, from our findings, there were key actors. There were key actors and non-key actors from our findings. The key actors were parents and childcare managers who were providing water directly and mostly on a daily basis. The non-key actors were working through the key actors, or they would be available to provide WASH services once in a while. For the networks, there were direct, possible, and desired networks. Most formal actors had direct networks, and those direct networks are the ones that would avail water directly to the childcare centers. But then there were also possible networks or connections that were felt at the community but would not avail water at the childcare centers. But then there were also desired connections or networks that had that were thought to have influence, but were not seen more at the community and even at the childcare centers. But then good to note that an actor could have more than one networks depending on the perception of the study participants. And for the role of actors, the role was seen to be based on access, ensuring access, and also promoting quality, as you can see in the photo. And for the authority was based on charisma, that and also it was based on values, such that if you had a charisma or passion and values for ensuring safety of children, believing in children, they would then ensure wash services are availed at the childcare centers. The government, on the other hand, was described to be having a formal and rational influence, which was not mostly, which was thought to not be practical or applicable in many childcare centers in informal settlements. And the interest of actors was ranging from income generation for children to access wash services and for compliance with the government regulations, and from promoting child health and preventing the spread of diseases. We conclude that provision of wash services in childcare centers may be realized when key actors work with networks to demand for services from desired networks. And also developing more direct networks is very key, and it's also key to convert desired and potential networks into direct networks. And lastly, actors should collaborate to strengthen existing networks that enhance wash services. And thank you to the funders, GCRF, UKRI, and also to the RISE Consortium, the study team, and my supervisors, Professor Penny, Phillips Howard, Professor Helen Elsie, and Professor Blessing. And thank you. For any question, feel free to share or send to my Gmail, ivychumo@gmail.com. Thanks, and if you have any question, thanks so much. For now, that's just it, but I will.
I think the last sentences was cut. Okay, so we're moving to the end of the session. Please, I'm sorry that we had to start late the session, so we will take 5 or 10 minutes of your time after 6. But I strongly recommend you to stay to the last presentation that is entitled "Communities Assess and Implement Practical Methods to Deal with Environmental Determinants of Slum Health: Lessons from India."
Thank you for the thank you to the earlier presenters who've presented on similar themes. I will go a little deeper into what the community can contribute to research. This study is set in Indore. It is more of an action research. And Indore is the 14th largest city in India, and has a urban population of 3 million. The method we used is the qualitative adaptation of WHO's Urban Health and Equity Assessment Response Tool. And we conducted participatory slum level assessments of sewerage access, garbage disposal, water supply issues, which Amanda also covered. And they have one of their sites is the same as Indore. We used some of our older work, which we did in 2005, 6, and 7, which determined the physical living environment factors that contribute to health and well-being. And we modified the World Health Organization's Urban Health Equity and Response Tool. These were the indicators that we modified from the WHO Urban Heart Tool. And this is how the assessment happened. So here, as you can notice, that I did not mention too much about what we did, because we did very little. And it was the communities who did everything, and you will not find anybody other than one person from the facilitators in the pictures. So we have been working for a long time and our roots are fairly deep. We are able to encourage the community to do the research themselves and make assessments and identify action and take action. So here you see on the top left, 3 ladies who are assessing on a chart where the names of the slums and the indicators are written, and they're assessing on green, yellow, and red. So green is for good condition on that indicator. For example, if it is a sewerage system, if the sewerage system is working well, it is green. If there is no sewerage system, it is red. And if the sewerage system is dysfunctional or suboptimally functional, it is yellow. On the top right is the chart, the output. It is small, so it may not be visible, but it shows the green, yellow, and red dots. And below that, bottom right also is the green, yellow, and red dots. So here it will be a little more visible. I just took out 2 indicators to show the sewerage system. These are 5 informal settlements of Indore. And the sewerage system in the lane was red in one informal settlement and green in the other informal settlements, where they submitted community requests to clean the sewerage system. The sewerage system gets clogged, as Amanda was saying, when there are heavy rains, there is a challenge with the sewerage system and it gets clogs and it sometimes flows back. Sometimes the sewage is on the lanes. So usually the authorities are able to respond within 1 month, sometimes 45 days, and they clear up the sewage system and it is back to optimal functionality. The gentle negotiation is usually done with the ward councillor. So we go quite close to the governance system in a city. Instead of going to the mayor, we reach the ward councillor. And he or she has the direct access to take the decision and get the work executed. The second example is the condition of the lane, whether the lane was unpaved, which would be red. If it is broken, it would be yellow. Or if it is well paved, it would be green. Here also the community submitted written requests and also reminders. Here we had to submit reminders because the municipal corporation can take many months to decide to repair or pave the lane. There is one example of slum, New Jagdish Nagar and Nandan Bagh. There is a lane where part of the lane is called by one name and another part is called by another name. One part has not been paved since 2016. And now we are in 2022. And they have a file of 10 requests and reminders, including reminders to the public accountability mechanism, which is called public hearing at the district magistrate's office. Here you see the how the community does the requesting. We use the phrase amiable demand-side negotiation through community requests and reminders. And what this does is that it helps the government utilize the funds. Because as you have heard across the world, there are funds for cities, and people have started calling them smart cities. But these are the unsmart people of those smart cities. Nobody wants to see them. In fact, some cities put up walls if there is a big tournament happening there. So on the left is the image of a handwritten community request. You see a few signatures and phone numbers very at the bottom of that application. In the middle is a picture of women's group members making a request to the ward councillor. The gentleman in spectacles is a ward councillor. On the right top, you have the picture of women making a reminder, submitting a reminder at the district magistrate's public hearing. It is called Jan Sunwai in Hindi in India, or in the Hindi-speaking part of India. And on the bottom right is the receipt of receiving the request from the district magistrate's office. It is an electronically generated receipt which has a reference number, which can then be pursued, because the example where I was mentioning that since 2016, there has been no progress on paving of a lane. They have several reminders which are available in the file, because at some point, if they get restless and they do something which will lead to an officer starting to call them, because they have their phone numbers, they can show them the file that we have submitted so many requests already. What are the outcomes that we observed through these efforts? Clogged sewerage lines were cleaned through coordination with the ward councillor in 8 of 10 slums for which requests were submitted. So 8 turned from red to green. Laying of new sewerage lines, here of 4 lanes for which requests were submitted, only 1 was paved during this period. So one turned from red to green. Sorry, this was about the sewerage lines, and then the paving of lines, 1 of 6 lanes turned from red to green. And then garbage collection, the garbage collection visits were improved. In Indore, there is a fairly robust garbage collection system, but the vans sometimes do not reach the informal settlement. So they have to make a request to the agency which partners with the Indore Municipal Corporation for garbage collection. And here the request was submitted for 9 slum lanes, and in 7, the response was positive. Now, what are the lessons that can be implemented elsewhere? This methodology is simple, it is low cost, easily understood by the less educated, by academics, by policymakers, implementers, and users' community wisdom. It can contribute to protracted lack of local data. Because we often say that there is no local data available. It is adaptable for NGOs and for policy and implementation guidelines. The method helps slum dwellers focus energies on actions to mitigate challenges rather than on continuing to tell the investigator the data. Collective self-efficacy, which is a group's shared belief in its ability to utilize information, is key to this type of effort. And it is important to focus on this type of strategy. Strategies should be built into government policies and implementation guidelines so that the fund utilization can be strengthened. Thank you.
Are there any questions for this last presentation? Yeah, there's one over there.
Thanks. So that was a great presentation, Siddharth. Yeah, I'm Tai Bayode from PhD student from Heidelberg University in Germany. So I've got two questions for you. The first question is that the findings, like what your findings of your research, do you think they would be similar in other slums in India, despite the cultural differences in India, and possibly if the solutions you provide could be useful in those other communities? Then the second question has to do with your garbage collection. Probably if distance to the garbage, what do you think if distance to the garbage might be some environmental determinants? Because sometimes it's not just about how often they clear the garbage, but probably the distance of those houses to those garbage, if they are of close proximity, if it could have some impact on their health, maybe propagation of vector diseases. So yeah.
Thank you. These findings would be similar in most Indian cities. So in my experience, I've seen cities in different parts of India. So the challenges of garbage or sewerage or paving of lanes or water supply, they're very similar across the country, other than the southern part of the country, particularly two states which are Tamil Nadu and Kerala. So this is different. I've seen slums in those states as well. And they're also similar in 3 African countries I visited and 1 South Asian country. So they're similar in Nairobi, Addis, Kigali, and Bangladesh. So they would not be very different in terms of these. There would be specific differences. So this study, as I was mentioned, focuses more on the action by the community, because the community keeps suffering for very long if we just spend 3 years in collecting data. So instead of doing that, we do the data collection, or rather the community does the data collection and takes the action on the spot, rather than waiting for somebody else or waiting for a big consultation to take action, because they are suffering from clogged sewerage and it is flowing back into their toilets. Regarding the garbage, in this particular city, the garbage collection is door to door. So it is not at one place, or there is no garbage dump. So this city, it is also rated as the cleanest city of the country. So the garbage collection is from the door, or if not the door, at least from the same lane. And so people can go and throw their wet waste or the kitchen waste and the non-biodegradable waste in 2 compartments of the truck.
Are there any other questions? Yeah, sure.
Now they contribute, take the on action in terms of making the change in themselves. So I guess it's a good comment and say congratulations.
Thank you, Dr. Uta. You've been following our work for the past 7 years. So it's good to hear that reinforcement from you.
Okay, I just want then to finish quoting you by saying, we did very little. The community did everything. And it was like quite sincere, but you did a lot of work. with the community, but you did a lot of work. So congratulations, a big applause.
Thank you.
So that was the end. I want to thank all the speakers for the amazing presentations, and also I want to thank you all for engaging in a really rich debate, for all the presentations, and then in the end all the staff that is here in the room that helping that this is possible. So thank you very much, and see you tomorrow.